surgeries. So to begin with, we have Dr. Rohit Shetty, and he'll be showcasing the biconvex lenticule, the shape matters. So essentially the ELITA on the J&J platform. So all to you, Dr. Rohit Shetty.
Thank you, sir. I realize that there are two talks on the similar subject, so this is a little longer video which has everything. So I'll just try to see if I can. This was done for deferred life surgery at ESCRS. So I can just forward a little bit because I think Dr. Maipali sir is also showing.
For a part of a trial where we demonstrated that we need to do a small nomogram adjustment in our geographical population. And we can use whatever nomogram you want here so that this will help in the final correction. There are your K readings here. This interface is something which I really enjoy. You know, it's beautiful. It has that the finesse of a beautiful refractive procedure. The refractive lenticule has a zone of 6 millimeters, transition zone of 8. It has an incision which is around 3 millimeters out here, and it gives you all the other data, the data of depth, the side cut angle. But what I want you to focus on here is the shape of the lenticule. For example, the shape of this lenticule is biconvex. It's very important because it's biconvex. When you have to understand this biconvex nature of the lenticule when you're actually dissecting it, which I'm going to demonstrate as we move on. Dear friends, now let's start with this procedure. Let's call our patient. Let's see how J&J has given us this new machine and how it can help us to bring the lenticule out just like self. How do we make the space? You pinch the
I'll just like forward it a little bit. I think
connect the suction apparatus. Then the patient interface cone is rotated and placed in the socket. We need to look at the PI scan, which scans 360 degrees of the interface to look for any submicron deficiencies which might hinder the suction and subsequent laser from creating a flap or a lenticule. This is a suction apparatus as we described and what goes into your cornea. And this is where I hold it in between my thumb and an index finger. It's important here that I place it gently, and when I place it here, I'm watching for scleral show and whether or not it's equal on all sides. This looks very good. So I ask to press the vacuum, suction on, and suction is on, and then the vacuum is achieved. Now I hold gently and move the bed to the area where the laser will be fired.
Sometimes at this point of time, if I see a lot of dry spot, I use this sponge with a little bit of fluid so that there are no dry spots. During this procedure, I gently bring down the patient interface cone. I'm looking at this image here. I'm also looking at where my hand is holding the suction ring. And I make sure my hands are steady, not tilted, and in parallel. I don't tilt the suction apparatus, and now the PI cone is gently touching. At this point of time, I look at the PI, and now the step is very important. This is the space with the vertical height. I move the knob slowly, gently, till I reach the green zone. Again ensuring I'm still in the green zone. Then I pinch the ring to allow the patient interface to come in contact with the cornea. And then I leave it, and making sure the meniscus is not in the area of the laser, and I push the meniscus as far away as possible. Here, I can adjust the position and ensure centration on the pupil center. We have also shown the fellow eye here, where we need to do a cyclotorsion compensation as well, which is much highlighted feature on this machine. So you can see the raster pattern of the laser being fired here, which hardly takes close to 17 odd seconds. We can see how the minimal spot to spot makes this possible and gives a smoother cut. Now it's making the incision.
What we have here is a 3D reconstruction of the lenticular shape in silk procedure compared to other comparative technologies. It shows us how the anterior-posterior orientation is biconvex. This is confirmed on OCT images as well. Keeping in mind this biconvex nature of the lenticule, we enter the anterior plane more acutely at the 12 o'clock position, similar to how you would kick a football. So we open up the incision like this and dissect 2 to 3 millimeters of the anterior plane like a wiper blade. After I do that, I enter the posterior plane, and the way to do it is to enter 3 to 4 millimeter away from the central entry like this and dissect in a similar way. Then the anterior plane is dissected in a windshield wiper motion. Subsequently, the posterior plane is dissected, keeping in mind that one needs to enter to the same side where the posterior plane has been opened. Dissection at 3 and 9 o'clock should be left for smooth-like procedure.
Thank you.
Thank you, Dr. Rohit, for that wonderful presentation. And I think that covers the entire gamut of lenticle extraction on this wonderful ELITA platform. So I think three major advantages that you've given is the shape, the biconvex, which essentially transforms into less dryness. And I think the depth also, in your studies, you mentioned that there is some element of the spherical liberations, or maybe the depth, which is enhanced in comparison. So quick word, what essentially, does this mean that when we are looking at refractive correction after the age of 40, and could it be a new arena for presbyopic kind of a...
Absolutely, sir. So you were there at the lenticule meeting. There was a big discussion about every lenticule after the applanation is taken out is a biconvex design. Of course, somewhere you may debate there's a different ball game altogether. But what we didn't have time to discuss is when you do a modeling work, when you take out a biconvex shape design, there is some amount of pressure put from both the posterior part of the cornea and from the anterior. When you dissect something which is more physiological in nature, that means both anterior and posterior curvature are matched, then your amount of pressure which is put on the top and below, there is difference in different type of lenticule. That's a modeling work being done, which is already published, and some of them it's in on way. So that means when you have when you match it with the more physiological shape, when you have pressure from both below and anterior and posterior, your cornea Young's modulus behaves completely differently. That has an impact on the pre or post-operative shape, and that is why you get less SA, more balanced sphericity, and of course, like you rightly said, definitely gives you a small EDOF-like picture on the cornea.
I had a question, Rohit. Since you've been a pioneer of Smile as well, and then now you've been, done actually the trials and you've been using it. What do you see as the big advantage of Smile over this, or Elita over Smile? Like, which are those few points? Like, I know that you always have an objective.
See, the big advantage I feel is, I'm sure all companies will also move towards different shapes. Is the shape, We at this point of time, I think there are two other work done by, say, Rushad and other people also suggest that the shape has a huge impact in how the cornea remodels itself, both mathematically and also, that is, I think, a big thing. And by creating a shape which is bypassing a lot of nerve bundles, there's a definite faster regeneration. So I think if these are the two things, and this has a huge role that in future, this keeps your sphericity minimally changed. That has an advantage when you look at it from a post-cataract and these patients, or the depth of focus may not be a great thing when you're 25, but when you turn 30, that's when you start stenopic symptoms set in. You feel tired, you feel headache, and all those things. So that has a huge role